Hello, everyone. Welcome to the fourth webinar in our series AI and the Invisible Workforce Task Shifting and Automation Risks, which is a part of the AI and Public Health Expert Dialogues co hosted by PATH and OECD and convened under the Public Health Impact through AI, the Fix AI initiative. Today's webinar is youth focused and organized in collaboration with Youth, the Youth Ownership of Digital Health at PATH, a platform committed to amplifying the role of young leaders in the digital health and AI transformation. For those joining for the first time, Public Health Impact through AI, the Fix AI initiative, is a flagship initiative of PATH to shape the AI for health ecosystem by accelerating innovations that advance universal health coverage and health equity. And my name is Resham. I oversee the initiative and the public health dialogues. Youth leadership is vital in digital health and AI, and infusing the healthcare ecosystem by co designing solutions, driving innovations, and advocating for equitable policies. Rapid advances in AI are transforming healthcare roles and demand a workforce ready to adapt. Youth brings that kind of digital literacy, digital fluency, creativity, advocacy needed to strengthen the capacities, policies, and ensuring that digital health and AI serve communities equitably throughout the global south and across the world regions. So today we are joined by a remarkable set of speakers, the youth leader, the visionaries of today and tomorrow, shaping the future of health, technology, human centered innovation, and who will be spotlighting the power of youth leadership in today's and tomorrow's healthcare ecosystem. We invite the audience to post your questions only in the Q&A box throughout the session. We'll surface some of these questions through open discussions at the end of the webinar, and speakers feel free to answer them as it suits you best. With that, I'd like to hand it over to my colleague Pallavi, who leads the Youth Initiative, to provide an overview of the initiative, and then that'll be followed by our co-host Eric from OECD for his opening remarks and context settings. Thank you so much, and it's an absolute pleasure to share this space with each one of you. And thank you for your patience throughout the 90 minutes moving forward. Over to you, Pallavi.
Thank you so much, Resham. Hi, everyone. I am Pallavi Jain, Program Lead in the Digital Health AI and MedTech team at PATH, and the Secretariat Lead for Youth Ownership of Digital Health. First of all, thank you so much, Eric and Resham, for inviting youth on your platform and giving a voice to young leaders in digital health and public health space. We much appreciate this opportunity. So, Youth Ownership of Digital Health is an initiative supported by the Gates Foundation with its Secretariat held at PATH. This is a volunteer-led community for digital health professionals under the age of 35, and it's designed to build leadership capacity, foster peer networks, and create a platform for knowledge exchange. The initiative essentially rests on three key pillars: community engagement, capacity building, and networking, all of which are aimed at nurturing young, well-informed, and responsible digital health leaders. Our mission is to provide young digital health professionals with increased representation, knowledge, and networks, enabling them to be well-informed, innovative, and responsible digital health leaders. We started our journey in July 2023, so in over 24 months, Youth has grown into a thriving, self-sustaining community of over 1,000 members across 45 countries. Our community prides itself on being gender inclusive, with over 51% of our members being women. And our members come from diverse sectors, including civil society organizations, consulting firms, startups, nonprofits, and the government bodies. As a community, we thrive on the passion of the digital health professionals who are a part of the community. And because of that, we operate on the principles of a community of practice, fostering collaboration, shared learning, ownership amongst the members. We follow a very democratic approach with its leadership being led by the Secretariat, which is led by me and supported by Sarah, with our 19-member core committee team, both from India and Africa, as well as, our cohorts of ambassadors and volunteers, who champion youth engagement in digital health. We foster 7 hybrid initiatives combining both online and offline engagements to ensure accessibility and inclusivity. These include a podcast series, webinar series, field visits, in-person leadership events, opportunities to publish. And these initiatives provide continuous opportunities for not only knowledge exchange, networking, and collaboration, but also for strengthening community bonds and fostering deep interpersonal connections, which are much needed in today's time. The initiatives have been developed completely in sync with our members' expectations, and we're continuously iterating them based on the evolving needs of our members. Going forward with the momentum that we've built over the last 2 years, we have recognized the need for setting up localized hubs and expanding our reach to a broader audience as well. As a result, we recently launched our exclusive Africa chapter and are soon going to be launching our first student chapter as well. I'm often asked that, why youth? What's the unique something that youth brings in? So it's a very simple answer, which is that, with the given inherent technological influence and savviness of the young practitioners and professionals of today, these are people who are essentially digital natives who possess a unique advantage in steering the digital health transformation which global healthcare systems are currently undergoing. So this positions these youth as beneficiaries as well as active participants in the ongoing digital health revolution. However, youth does need to be strategically positioned so that they're able to take advantage of the changes that are happening in the sector. So keeping this in mind, we wanted to create a platform that helps in upskilling youth, not only in the context of digital health, but also help them, being empowered leaders and creating a cadre of empowered healthcare professionals that can contribute to strengthening the health systems at large. So this is just I would say an initiative from our side, and we hope that this becomes into a movement. And I'm very glad that today you'll get to hear from some of our members. And once again, thank you so much, and I'm looking forward to this conversation. Resham, over to you.
Thank you so much, Palvi. This is really helpful, not just for us, but also for those who are joining us today to learn more about youth and in different ways that they could contribute to the digital health and as well as the AI space. So thank you so much for that. Over to you, Eric, our co-host from OECD, for your opening remarks
Sure.
on context setting.
Thank you, Resham. I feel like the old man in this call, which I have to say is not the best feeling, but that's okay. It is actually, you know what? No, it is a good feeling because it is exciting for me to be energized by the different thinking, but also the energies that naturally come from the youth populations. Frankly, the whole reason why we're the transformation of health is going to be most felt and achieved with the help of and for the benefit of many of the youth people who are here. And it will happen because of people like the leaders who are on this call today. So I'm very thrilled to be engaged with and actively listening to this discussion. Just by way of context for the audience, I'll put some of the links in the chat. This is the 4th webinar series. We've talked consciously, we're trying to build up some Lego bricks over the span of the various conversations. We started talking about connectivity, like low connectivity and otherwise resource constrained environments. Frankly, everyone is in some form of resource constrained environment right now. Then we started moving through the aspects of culture. How do we embed AI into the culture of public sector in its application in health? Then we addressed one of the major challenges that we have around AI in health, which is its financing. We did that at the end of August. And so today, now we're really going to focus on the people who are at the heart of this transformation, which is the workforce, both the AI and the invisible workforce that's necessary to make this transition happen for the benefits of people and our health systems and our communities at large. So I'm really excited to hear what our panelists have to say today. So with that, I will pass it back to you, I guess, to Sarah.
Thank you so much, Eric, and thank you so much, Pallavi and Resham, for telling us about Fix AI as well as yours. And Resham, you're right on spot. We have an incredible lineup of very diverse youth representatives today on our panel who come from such different disciplines. And I'm now going to invite our panelists to introduce themselves and tell us a little more about the work that they do. Anima, I think we can start with you.
Hi, good evening, everybody, and good afternoon and good morning to people tuning in from different parts of the world today with us. Firstly, I would like to thank the people who thought that I would be the right person to speak and, discuss my opinions on AI and the healthcare workforce today. My name is Arnima Rawat. I am currently working in the national deployment team of Vadhwani Institute for Artificial Intelligence. So my work is focused on deployment of solutions, adoption and scaling of these solutions, which are in healthcare, education, and agriculture space across various states in the country. Prior to this, I've worked in strategy and implementation of DigiGov projects such as CoWIN, which was the COVID-19 vaccination platform of India, as well as National Non-Communicable Diseases Platform. And besides that, I have worked in certain research and implementation and procurement projects for various healthcare government spaces. So yeah, thank you.
Thank you so much, Anima. Katerina, over to you.
Hi, everyone. As Anima said, it's fantastic that we are gathering all here today to talk about such an important topic. I think, as Eric said, this is well in line to build up this pile of Lego all together. And I think we're also going to have a fantastic discussion. So thank you very much, of course, Sarah, Risham, and Pallavi, for allowing us to be here all together today. So my name is Katarina Vujovic. I work for the OECD, the digital health team, and my main focus is on health data governance practices, on AI adoption, and as well impact on the health workforce. And I'll be more than glad to share some of our recent work that we conducted in that field.
Thank you so much, Katerina. Kehinde?
All right. Good afternoon, everyone. It's a pleasure to be here, and I'm really excited for the next line of conversation that would happen regarding the discuss. So my name is Muraino Kende. I work as a senior analyst with the Clinton Health Access Initiative based in Nigeria, but I'm based in Lagos. In terms of my role or my work, focus on strengthening primary healthcare systems and structures, leveraging digitization, but more importantly, how can we improve operations, service delivery and uptake of services at a grassroots level in Nigeria, focused with Lagos State. So thank you so much. I'm looking forward to the conversation. Thank you.
Thank you, Kehinde. Manoj?
Hi, everyone. Thanks for having me over. Always great to be back and talking with co-panelists from the Youth family and to the Youth family. So Manoj, co-founder of Nemo Care Wellness. We're a startup focused on revolutionizing newborn care, and we do this with the help of technology tools like wearable devices and an AI platform, which allows us to identify the babies which are at risk, give the healthcare workers more time, and ensure that their tasks are done more efficiently. So better patient care using technology aid and public health is our target right now, but we are eventually ensuring that we want to give equitable care to every baby, irrespective of where the baby is born.
That's an awesome vision. Thank you so much, Manoj. Sharon, over to you.
So greetings of the day, everybody. Very happy to be here with the Youth family, chit-chatting on a Thursday evening here. So I am Dr. Sharan Murali. I am a medical doctor who is trained in public health, and I've been working as a scientist in the Indian Council of Medical Research, National Institute of Epidemiology at Chennai, India, for the last almost 5 years, with key focus on field epidemiology, non-communicable diseases, and digital health. I work at the intersection of these areas, trying to leverage technology to bring in more automated workflows to ease the already exhausted health workforce of the country. And that's where I'll be speaking on today. So excited for today's discussion. Back to you, Sarah.
Thank you, Sharon. Oseni?
Hello, good afternoon. My name is Odrago Hussein. I'm public health physician specialized in digital health. I'm working now with Doctor Without Border in Ivory Coast. And my main area of work with the organization is to lead the governance of data and also the implementation strategy for digital health solution. The objective is to have data with good quality for project monitoring and decision making, and also help physicians in the field with digital tools to improve the quality of care and the patient care. I'm happy to be there with you to talk more about the use of artificial intelligence, the workforce, and so on. Thank you. Over to you.
Thank you so much, Hussaini. And with that, we will now deep dive into the questions for the webinar today. As mentioned earlier, audience, if you have any questions, please put them in the Q&A box. All right. So we've been talking about AI, and there have been some extremely exciting advancements which have been taking place. However, when it comes to AI in the workforce, we're still at quite an early stage, and we don't necessarily understand all the implications as of yet. Speakers, my first question is to all of you. What is something which excites you and something which concerns you about AI's role in the health workforce transformation? Hussaini, would you like to go first?
Okay, thank you, Sarah. What is exciting for me regarding the AI is that artificial intelligence can free up healthcare workers and reduce EV admin tasks and allow them to be more focused on patients. But we have to be careful with some aspect regarding the use of artificial intelligence because of the lack of the access to digital tools, lack of training in many underserved areas like African country. That's why we have to improve the use of AI by leveraging digital resources, training to these people to allow them to be more focused on patients. Thank you.
Thank you, Hussaini. Sharon?
So very excited about it, thinking about the possibilities of using AI. But when coming to a country like India, where bulk of the data is sitting in paper, and then trying to adopt systems from the Western world, and building models with the Western data, and then trying to run it in India, there is a big question mark on is it the right approach. The second one is, okay, let's start making data in the country. Now the problem is, how much time is that going to take? Because we are a lot in number, we're already at stress, and how much time do we have to generate the data now, or bring all the paper onto the digital platform and then train our models and then start implementing it? Like, whatever you learn today in AI might not be valid tomorrow, right? So it's moving really quick. So that's the danger that we're looking at. And considering the latest Google Gemini's photo image and the legalities that are coming up to it, scary too at the same time. Yeah, let's hear from others too.
Thank you, Sharon. Very, very important points that you've brought up. Anima, we'd love to hear your take on this.
Yeah, thanks, Sarah. Generally, what excites me about AI would be just talking dogs, roasting cats on a podcast, which is very human-like. But when it comes to healthcare workforce, I think something that really helps the healthcare workforce is reducing their workload and burden. Like, and especially like the frontline workers who are supposedly the linchpin of various systems in our country, they're burdened with so many activities, so many programmatic tasks. Just them getting a sigh of relief, just like reducing an hour's workload, I think that's quite helpful. Something that concerns me about AI particularly is, what if we start relying on technology too much, so much so that there is no human in the loop approach present anymore, because we think that this technology is going to give me the best results. And especially when it comes to healthcare, we're dealing with lives and health of human beings. So it becomes all the more precarious to think about I really don't want, like, as collectively as humans, I think we should not let that day come where human is not looking at if somebody has cancer or not, for example, and that is just like that oversight is ignored, and yeah, like that leads to a problem in the human life.
Thank you, Anima. Some very important points, and we will be touching upon these later in the webinar. Katerina, over to you.
Thanks. Thank you, of course, Sarah, for that question. I think with the quite valuable aspects have been shared by the other panelists. But only all in all, how we can resume it is that this AI is absolutely pushing the boundaries of what is possible. And I think it's definitely going to redesign healthcare system. It's not just going to be a tool like we saw, for example, with electronic health records that we're going to be able to plug in. Of course, if we manage to put data in digital form, as Sharon mentioned, that is not, of course, the case yet in many countries. But I think that this is really going to enable this wholesome transformation of healthcare system. And of course, as it was already said, it's going to free up time of healthcare providers and as well help them to refocus more on this human-centric aspect of healthcare, whether it is empathy or as well trust, that no algorithm is actually going to be able to replicate in the near future. On the other hand, what does concern me so far and what we're already seeing is that we are definitely moving fast. Sharon said it very well. Who is moving fast? The technology sector is definitely pushing the healthcare sector at a pace that makes the sector lag behind. And in that sense, where the healthcare sector, or healthcare providers, and us included, should start to focus on is how to make or how to align the pace of the healthcare sector with the ethos, I would say like that, of healthcare. And in that sense, to do no harm to patients. And I think if we manage to align these two forces, we're absolutely going to reduce this risk that we are witnessing right now. And I think this is a challenge that should be tackled across the globe.
Thank you, Katrina. That is a very critical insight that you brought about up. Kehinde, over to you.
All right, thank you so much. I think everyone has really touched on critical points, but just coming from the standpoint of Africa, in terms of the opportunities that exist, I think one of the biggest thing is healthcare workers in Africa are, plagued with so much of administrative burden. So in a typical facility, a typical healthcare worker would have to fill different registers, and document manually. But then AI brings the opportunity of automation and helps them with that relief of administrative burden. So that's one of the biggest areas that I'm really excited about. Additionally, again, looking at clinical decision support, which helps healthcare workers to have some bit of second opinion, but then doesn't remove them from using their clinical knowledge to take a final decision. That's critical for us, and I think is quite remarkable with the intervention of AI. In terms of the biggest downside to it is it again widens the digital divide gap, where you find healthcare workers who have been trained previously as far back as 20, 30 years through the normal pen and paper, struggle a bit to understand why they need to have a tablet or a smartphone and use those devices or this technology in their facilities. And so the much older you get, the more difficult it is to onboard and adopt. And again, it widens that inequity gap. So that's something I'm really scared about with the interventions or the advent of AI. Thank you.
Thank you so much, Hussaini. Manoj, over to you now.
Yeah, so I think so many perspectives and thoughts that kept me getting deep into my thought. I'll keep it crisp. So I think what excites me is that irrespective of where a patient is going to be, these healthcare providers can now be augmented. And that gut feel that a doctor builds with time and experience and exposure, I think that's the tool that AI can now model. And even a young professional can use this as a reference. So I think that will give the end user, the end beneficiary, patients will benefit a lot, and which is going to make the healthcare providers smile as well, because that's what they're striving for. And the concern, I think, is about who's going to be accountable, and can we explain what the black box is doing? And rightly pointed out, saying how are we going to get clean label data with such massive populations to build foundational models for population specific algorithms. So these were my thoughts.
Thank you so much, speakers. You have very beautifully set the context for the webinar, and so many points that you've brought about are things that we will be discussing through the course of the webinar. So thank you so much for your perspectives. And I'm now going to segue to my first question. And as many of the speakers have already alluded, AI presents this opportunity to help reduce the burden of our healthcare workforce. And we know that overburdened healthcare staff, because they're so overburdened with their work, that is the number one reason for workforce attrition. There is an estimate by the World Health Organization which says that we may face a shortage of 11 million healthcare workers by 2030. My first question is to Dr. Hussaini and Manoj, both of you as innovators, and Dr. Hussaini, you're a clinician as well. I'd like to ask you, with these developments taking place in AI, do we have an opportunity to really transform and strengthen our existing healthcare systems? And would you say how would these new AI developments help support our healthcare workforce?
Thank you, Sarah, for that. Yes, absolutely. I think AI can help us to accomplish more things, but artificial intelligence is not there to replace health workers. It's to support health workers. And I identify three opportunities regarding that. One is has many as we talked during the first step, it will allow us to reduce the workload by using automation of reporting, transcription, and data cleaning. And these things will allow nurses and physicians to spend more time with patients, not on admin process and other repetitive tasks. The second opportunity AI can give us is empower community health workers. I know that in developed countries, it's not something used more, but in developing countries, community health workers play a pivotal role at the front line side. Empowering these community health workers with artificial intelligence tools can allow them to detect diseases at the early stage and refer patients to hospital. If patients are at hospital at the real time, it will reduce the workload and the burden at emergency side, and health workers will be free and more focused on other type of diseases. They must be careful in the treatment. The third thing is that AI can help us address the workforce shortage. We know that it will not to replace, but using AI will allow us to reduce the burden. Using AI combined with telemedicine can allow us to provide health to underserved area. Even if we don't have a lot of health professional in some area, AI can help us to mitigate their challenge. And what I want to say finally is that in many countries, like developing countries, we have to invest more in training, in infrastructure, and strong governance to achieve this objective. Because having artificial intelligence tools which can allow us to have a great diagnosis of tuberculosis, diabetes, and so on is great. But if the local population don't have the resources, the means, and the training to use it, it will not be helpful. That's why I said we have a big opportunity to use AI in the healthcare area, but we have to invest more in some aspect like training, like infrastructure to achieve that and have a good way to mitigate these shortages announced by the World Health Organization. Thank you.
Lovely points for me to pick up and build on top of. So when we started out the work that we are doing at NemoCare, so one of the biggest challenges was the parity of the number of healthcare workers, the number of babies that they had to take care. We almost had the ratio of 1:20. It kept getting higher at the gap as we kept going to harder to reach places. And what we started realizing is saying, as much as we can cut down adding more burden, because one of the major tasks that they're doing was taking notes for handouts, because there was a lot of shift work that was going on. There was some handover that had to be done. So there was almost 1/4 of the time that was going into just writing in notes so that nothing is missed out. So we had to ensure saying we don't add burden. That was one of the first things we had to take care of. But as we started building it, we realized saying we want to augment so that one nursing staff or healthcare worker can look at multiple of these patients or newborns from a single window. It could, I mean, the tools we use were remote patient monitoring, centralized monitoring. But the key factor that we realized was how do we optimize the resources? And this, for us, surprising, was not just a hard to reach place or resource constraint settings. Even in a corporate setting, we had this as an issue, saying they knew what care to be given, but which patient, what has to be mapped, which nursing staff to map to whom. I think that was something critical where we realized saying technology, AI started helping in saying when we start stratifying risk and say that this patient needs more attention or this nursing staff has some tasks left, and we had to ensure by uh, minimal touch points for capturing the data points as well, because if you had to take some decisions, you need data, you already know they're overworked. We had to ensure that all of this is taken care of, but the end goal was always to optimize their workflows and ensure that their work skills are augmented. I think that was the approach that we've taken so far. And as we get closer to the field, we're realizing saying uh, the gaps there, the gap is quite big to bridge as much of technology, but under the supervision of these healthcare workers.
Thank you so much, Hussaini and Manoj, for your points. I think you both have wonderfully summarized how AI is helping augment the healthcare workforce, and there's so many advantages to it. However, what we're seeing is that a lot of healthcare workers are, in fact, very hesitant about AI coming into the systems, and they have a lot of anxieties and some reservations around it. Dr. Sharan, I want to ask this question to you. You are a physician and you work very closely with healthcare staff on the ground. Could you tell us what the general atmosphere is around AI being introduced, and what some of these apprehensions that healthcare workers feel, with AI being introduced within their work streams is?
Okay. Thanks, Sarah, for that question. So I would like to take a step back at this moment, and try to bring more attention to what the field reality is. The healthcare system and its staff, that is in the Indian context, are under tremendous stress and very overburdened. The same staff is basically pushed to do multiple responsibilities. And we know in India, we have healthcare programs in different verticals. That is, tuberculosis is a vertical program. Vector-borne diseases is a vertical program. But all these verticals are basically only on the top. When it comes to the bottom, it's the same person who will have to cater to all these verticals. Even now, telemedicine is also one of the verticals. So each program, and then what do they do is each of these verticals come up with their own solutions, right? It can be tech solutions, it can be paper-based solutions. So whether it is AI or not AI, all of these have created a lot of burden, because the same ANM or the community health worker will have to enter data on a daily basis in around 36 applications. That number itself is a very scary thing for me. That means that person will end up entering data and not talking to patients, right? And then the burden of this adds on by the problem that, the portal doesn't open, or the reports that they want to download doesn't get downloaded. So it adds a problem that, there is a breach to the trust in the system. So I will enter the data, but I still don't know if I'll get back this data for my day-to-day analytics or my reporting. So I might have to write and keep it somewhere else also, and that gets added on like a problem. So we have observed that in the NCD clinics, right, in Punjab and in Madhya Pradesh, that we can save almost 20% of the time of a nurse by just digitalizing their workflow and taking away registers from their place. So like, have a QR code, scan the data on the mobile, get the reports of previous BP values, and then look at the medications and then do it, rather than entering into multiple registers and using manual calculations and follow-ups. So now let me try to again address the elephant in the room. Public health is politics, right? Frequent changes in political commitments leading to changes in the technologies that are being used, which again breaks the trust. I slowly get used to a technology that was introduced, and by the time I get very well versed with it, it changes. Now, again, there is a new technology in place, which I have to again ground up, start again. So why do these fail, right? So basically the problem what we feel is a lack of co-designing it. It's mostly done from bottoms up. From top down, which fails in the field. Let's just take for an example, although we understand that now the internet is massive coverage all over India, when you need it, it's not there, right? And sometimes offline first is a very basic feature that you might have to build in, which is forgotten. And then the patient is there, the worker is trying to access his health record, and it fails. They start writing it down somewhere, and that's where all the problems start. So maybe trying to build more trust by co-designing these is the first step, and that is where the anxiety starts building up. I don't know what is going to happen if I put the data today. I don't know if tomorrow I can still see that data. And this is very well reported from Punjab and various other states also. Yeah, so we'll talk more on this. Sarah, back to you.
Thank you so much, Sharon. I think, data duplication and duplication of efforts is something which takes up so much of our healthcare workers' time, especially those in the front lines. We have studies which show that they spend 5 to 6 hours of the day just working around data. So naturally, there's going to be a lot of resistance there when you're bringing these tools, because they might think that this is just an additional burden on a layer of problems which already exist. So thank you so much, Sharon. Katrina, my question is now towards you. You work very closely at the intersection of AI and the health workforce across OECD countries. My question is, what have some of your general findings been on this matter? And, what role is AI playing on the health workforce from an employment perspective? Are we seeing any differences in implications for the different health cadres that we have, and what that implication might be for the non-medical folks who are part of our health ecosystems?
Right, thanks for this question, Sarah. And I'm going to take a bit of a step back, a bit further away from the field. But in general, AI's impact on the health workforce across OECD countries was not that much of a job loss, but rather of a task shifting. And from an unemployment perspective, AI, of course, tends to automate narrow, repetitive activities rather than entire roles. And it also has the potential to take on more than 30% of time-consuming tasks. And that's already something that has been shared in this discussion, where administration is taking so much of healthcare providers' time. And here, AI is providing this potential. And so all in all, this is also going to reshape employment patterns through a positive augmentation of existing workforce capabilities. And importantly, the OECD published a report somewhere last year where they found that around 70% of clinicians are not afraid of being replaced by AI, but they're afraid and they're concerned of not being involved in the process of developing those tools. So we see here the fear, not much of AI, but of being missed in the process of deploying it. And now if we look at for clinicians or frontline staff, so of course AI is increasingly being used to ease workload pressures. In radiology, for instance, in the National Health System in the UK, there are several AI systems that have been piloted that triage chest X-rays, and they're helping actually to flag anomalies, and they're also speeding up the radiologist's time in actually spotting those anomalies for conditions including tuberculosis, but as well lung cancer. In Denmark, on the other hand, hospitals are starting to use AI scribe more intensively. This is on the one hand, of course, helping to transcribe data or information much more rapidly, but as well to reshape, if I can say like that, and to analyze summaries of the health encounter that occurred. And I think when it comes to administrative application of AI, we've seen the highest uptake with AI scribe in the past year, with more than this increase was higher than 600% over 1 year, and it helps to save around 1 minute per visit. And in the United States, a study was conducted, and it found that more than 15,000 hours can be saved annually through the usage of AI scribe. So we definitely see this impact actually on frontline health workers, where it helps to streamline the workflow, but as well to reduce the burden, because the demand is just getting higher and higher, and we need to help clinicians to have the right tools in hands to somehow mitigate this demand. Now, alongside, of course, the impact on frontline workers, what we've seen across OECD countries is the emergence of new type of roles, and those are called the hybrid roles. What does it mean? It's actually roles that are at the intersection between the healthcare sector and as well the technology sector. So those professionals that sit at this intersection are capable to blending in, if I can say like that, clinical experience with technology practice. And we have, for example, chief medical information officers that are starting to bloom in Canada or in the United States, digital platform managers in France, but as well digital nurse specialists in the UK. And these, for example, are currently being developed across various hospitals. And I think the most interesting one that we're seeing right now, so radiology is definitely the field that has seen the highest intake of AI, of course, through investment that occurred in the past decades, but as well, this was the field that was perceived as the low-hanging fruit, if I may say like that, where it was very helpful to help radiologists to detect those anomalies in a faster way. And in that sense, in Canada or in Japan, we've seen AI safety officers. So those are new roles that are actually helping radiologists on how to leverage those tools more efficiently. On the one hand, of course, to shorten the waiting time for patients, waiting to see what's happening, let's say like that, into their body, but as well for clinicians to be more capable in as well reducing medical errors that we can occur. So all in all, we can see that the impact is definitely diverse throughout the various roles that exist within healthcare.
Katrina, those were some incredibly interesting insights, especially, the ones you mentioned about new emerging roles within the sector. And you've also mentioned some of the good impact that we're seeing, with AI being introduced in the healthcare setting. Thank you so much for your response. I'm now going to move over to Kehinde. Kehinde, now that we're seeing the advent of AI in healthcare, that is also now in turn creating a demand for new skills for healthcare providers to be more digitally literate and for them to be comfortable using AI systems, right? You work very closely with healthcare staff across West Africa. I wanted to ask you, do you feel that there is an urgency for us to now reskill our healthcare workers to make them more AI systems ready? And what would you say some of these new skills or reskilling areas are?
All right, thank you so much. In terms of urgency, there's a huge urgency that we need to take or pay attention to, most especially for Africa, because when you look at the emergence of AI in Africa and for health specifically, one of the areas that is of major concern is the confidence and the ability to use digital technologies. That's a major issue. So we have healthcare workers who do not even enjoy or are confident enough to use these systems, right? And so the first step is, how can you take them from not being confident to being confident? And that takes a lot of energy and a lot of capacity building. And so if you don't really touch on that major aspect, you lose them. And then everyone is going at a much faster pace. Technologies are always getting developed every single day, and they're always going to be introduced into your health system because that's the new normal, right? And so I think if we don't start building those capacities in healthcare workers, and this starts from the government, you have primary healthcare systems or structures, secondary and tertiary. How can you remodel your refresher trainings to have all of this capacity building segments in them? I know you always want to improve or train or retrain healthcare workers on, postpartum hemorrhage, different triages, but can you start just including those things there so they are more familiar? And really the biggest area that we should start pay attention to, it's not even at healthcare worker level, it's when they're in medical school, right? Because they are trained on clinicals, right? But if you start from medical school and train them from the scratch, it becomes easy to adopt and jump on, right? In terms of the skill gap that I've seen, just from my experience working on several projects that are focused on this, aside from the fact that there's that capacity gap, is just the soft skills, adaptability. Just like Sharon mentioned, there are several tools that are going to be brought for different programs. It can be NCDs, it can be maternal health, but that willingness and flexibility to adapt is very important. And so that openness to say, you know what, it's not a tool I've been used to, but how can I learn it? And how am I willing, or what extra mile am I willing to go? Yes, we recognize the fact that it's not the ideal approach to overburdening healthcare workers, but that willingness to go a long way to improve their capacity, their ability for the next, this generation or this, century that we are in with AI.
Thank you, Sani. And it's very true what you said about the confidence part. Nobody will use a tool which makes them feel dumb. And this is something I once heard in this incredible design thinking session that I went to. So we need to make these tools in such a way that there is a smaller learning curve, and we need to also build, when we're talking about building technical skills, but we need to build the soft skill of our workers. So very wonderfully said. Now, Anima, my question is to you. Now, while we're on this topic of reskilling, it's very important that we bring an equity perspective here, right? We know that across the world, especially in lower middle income countries and countries where resource constraint exists, a lot of the healthcare staff, a lot of medical students don't have access to digital systems, let alone AI systems. And as Kennedy was just mentioning about training of frontline workers, they have a huge learning curve. It's not something that they get, in the first go, right? They don't necessarily have access to trainers who will teach them how to use these tools. My question is, from a policy perspective, how can we, ensure that these new AI integrated health systems don't widen inequity within our existing health workforces, and how can they be designed to be more inclusive?
Okay, so to answer your question in brief, it is to lead with empathy, as Katrina also highlighted, right? I'll touch upon a few things here. Firstly, it's about the design. When it comes to design, I think we need to focus on embedding AI solutions in the very systems that these healthcare workers are a part of and they rely on, and to design solutions that become a sustainable part of the existing public infrastructure. So in order to reduce inequity, the design should be focused on, sort of reducing the cognitive workload that is there on the workforce, and not like increasing it, that, this technology is so difficult. First, I need to learn how it's working, and then I'll be able to accomplish something with it. Keeping low resource settings in mind, I think offline solutions are a very good solution to fall back on wherever it's plausible in the AI solution that is being built. I'll give you a small example about how, keeping a good design in mind works. So in one of the design researches that our organization did, they found out how this edit icon, right, which is so prevalent, it's everywhere, and all of us know how to use it because we are so used to using it. But in our design research, we realized how months after deployment of our solutions, healthcare workers did not know what this pencil icon means. So when a solution is designed keeping in mind um, things that are obvious to us, certain mental models that we function with without keeping in mind who we are building for, I think that makes a massive difference. So leading with empathy, designing for the end user that is actually going to use your solution, that that will sort of like help to reduce the inequity that comes with just sacrosanct and structured structures that we function with. Secondly, of course, is training and upskilling. There needs to be a focus on this, especially from a national point of view. Like, you as a nation needs to recognize that everyone needs upskilling now, and especially healthcare workers who might not have learned all of these things in their curriculum, in their medical schools. But now, as the world is progressing towards using technology solutions, uh, like, we as Vadhvani AI, we take pride in doing these initiatives where in consultation with states, we do upskilling of frontline workers, not for endpoint solutions. The idea is for them to understand what is technology, what is AI, how is it going to help me. And once they realize how it's going to help them, they will want to know, how do I do it to make my life easier, right? And then when it comes to how government can make policies, in during program implementation planning, during budgeting, when you do budgeting for certain sectors. So in healthcare sector, they should account for tech devices that can actually help these workers, uh, and not rely on their personal devices, which might not just be there also. Thirdly, I would like to focus on a tiered deployment. There has to be a staggered approach to deployment where you let healthcare workers continue with their traditional methods of keeping their offline registers and offline records until they have the trust and the confidence to really use the solution that has been made for them. So there has to be a phase where you continue to let them use offline records, and then a phase will come, hopefully, where all of that they will be done with, and everything will be automated, and everything will be running smoothly. And of course, when it comes to like designing good solutions, there has to be a continuous learning and iterative approach. So we keep learning from our end users, we keep taking feedback from them, and then we keep customizing the solution for their best benefit.
Thank you so much, Anima. And you mentioned this point about how often these AI tools are not designed keeping the end users in mind, right? When we go deploy AI tools in real world settings, we have met with so many caveats and challenges, and this is predominantly a very major one, apart from things like environmental challenges or resource constraints, amongst others. I know, Anima, you and Useni have a lot of considerable experience within this domain because you both have deployed AI tools and digital tools across parts of India and Ivory Coast. I'm just going to, ping you guys further to tell us a little more about your experience deploying these tools, some case studies or examples that you might have. And I know, Anima, you've talked a little about how healthcare workers have reacted to, the introduction of these tools, but how can we support those introductions to be done in a more seamless manner? I think Dr. Sani, you can go here.
Okay, thank you, Sarah. You're right. During my experience, when we deployed artificial intelligence tools for community health workers, we faced many type of reaction. We have a reaction which were more encouraging and some reaction which were not. But most of time, overall are very encouraging. For the health workers, especially community health workers, they think that the artificial intelligence tools will take their place. It's like a replacement. If for specific activities we need 10 community health workers, with artificial intelligence, it can be less than that. It's some kind of reaction we faced. And also regarding the complexity of the tools. The tools sometimes don't reflect the real need of community health workers in the field. And has a positive reaction, uh, we gather some feedback regarding the fact that the artificial intelligence tools can allow them to reduce the workload by automatization of repetitive action, and also to allow them to be more confident when they refer patients to physician. Having a second opinion regarding the diagnosis of patient can allow them to be more confident. This is the overall reaction we have. But what I learned from their reaction and from this implementation is that to have more successful implementation, you have to take care from 3 points. One is, I know it's not especially for artificial intelligence, even for any other digital health tools, like data collection tools and so on. You have to design the tools with the frontline workers. If it's for community health workers must be at the first step. During the first implementation, during the development of the tools, you have to integrate community health workers to have idea on what the tools must be to reflect more their needs. And the second thing is capacity building. What we learn is that capacity building during implementation is not one of training, but a continued ongoing mentorship on the use of the system. And as we don't have a lot of professional for continuous capacity building, what we did is to strengthen the knowledge of some of community health workers with good knowledge to support the other community health workers if they have a specific need on capacity building. And the first thing is to adapt the solution to the local context. I can take some example like tools for data collection. It's the same for artificial intelligence. If you use a tools with a question, community health worker has to ask to people, and people has to give a answer. Sometimes, if community health worker explain the question to those people, they cannot understand very well. But if you adapt the tools to the local context, like using voice, we can integrate voice to the question, and voice comes from specialized healthcare professional talking the local language. It will be more helpful for the patient to replay and give the right answer. And the patient also can be more confident on that. And the second thing is to adopt the solution regarding the context on connectivity. Most of time in underserved area, you have a lack of connectivity. The best thing is to have offline solution. For AI, it's not something which is widely used, but having algorithm which must be used by community health workers without internet connection is a great thing for underserved area, because no need to have internet, no need to have more resources for the connectivity. And the final thing is to create the thing with some type of communication figures, like instead of using text, you can use some image or icon to express more what the tools or what the question call about, to allow them to understand and scroll easily in the tools where when they use it in the field. This is some kind of experience we learned and we integrated during some implementation, and it works well if it's adapted to the local context and also adapted to the reality of the country. I think this is what I have as experience and feedback regarding that. Thank you.
Thank you, Sani. Anima, we can quickly have your response to this.
Yeah, so one thing that I learned in my organization is that technology should just be the probably the last thing that we care about, even though we work at the core of tech. But we are building solutions and deploying those solutions for the citizens. So we try to live life of those users. We try to understand their problems and then work with the public systems to co-create with them, test and integrate the solutions in the public infrastructure. And especially being from India, which comes with a vast complexity of so much diversity, right? This diversity also helps us safeguard against certain blind spots, because we are anyway building our products for a diverse population and deploying it in different context settings. Uh, I'll give two examples here. One is a solution that helps us to detect pulmonary TB, which is such a simple solution. With a smartphone, these healthcare workers can take solicited cough sounds of patients. And with the cough sounds, the AI model gives inferences whether the person has pulmonary TB or not. Now, this has helped so much. This has helped the healthcare workers so much in settings where screening methods are so inadequate, chest X-rays are not available. It helps in increasing the screening and the programmatic outputs of the tuberculosis program that we have in India. Second solution that I would like to talk about is Shishu Mapan, which is essentially for ASHA workers. So Dr. Manoj might agree with this. Um, as per the maternal and child health program, under the newborn care, the ashas have to go door to door to basically see what is the newborn like in the first 42 days. It's very important to figure out whether the newborn is in the healthy trajectory of a healthy child. So the ashas traditionally, they go to door to door. They go with a heavy weighing scale. They weigh the child. They measure the child. They put everything in a register, and all of that entails a lot of time. And it must be, I'm sure, tiring for them to carry that heavy scale. The solution that we have is just using a smartphone. Ashas take a recording of the baby on the floor, left to right, top to bottom, and using that video, the AI model gives inferences about child's weight, length, chest circumference, and all these things that are required to determine whether a child is happy or not. Now, solutions like these, of course, make healthcare workers very happy because it reduces their workload, it makes their life easier. Anyway, they have to carry a smartphone for 36 other applications that Sharon talked about. Might as well make it simpler for them with the existing resources that they have. And and something like this model, right? As I was talking, as Oseni was also talking about contextualization. We have such diverse states, and in different parts of the country, we have children who are also very different. So we contextualize our solution to determine that this child from Northeast may not be similar to somebody from South India. So all of that work goes into building a solution that eventually makes the healthcare professional happy and makes their life easier.
That's a very interesting case study. Thank you so much, Nima. Quickly now over to Katrina and Sharon. Katrina, at the beginning of the webinar, you mentioned about how a lot of healthcare workers feel like they're not included in the design and development of AI tools. My question to both of you is that how can we, support their inclusion in the process to create AI tools that are actually keeping in mind the workers are going to use them?
I can jump in if Sharon, if it's fine for you. Okay, amazing. Thank you so much. Thank you for this valuable question. And I think Oseni said it already perfectly well, where he said that those tools are not reflecting local needs. And that's something that is also echoed in one of the studies that we've conducted recently, where we try to analyze the actual usage and as well impact of AI tools on healthcare professionals. And definitely what we're currently seeing across OECD countries is that this human by design factor is missing within AI tools, whether it is for individuals or as well for healthcare providers. And the result is predictable, if I may say like that, where the system are perfectly working in a control environment, but once it gets into the reality, well, this is where it starts to fall short, actually, where it doesn't align to the clinical needs, because reality is far more complex and nuanced than those control settings. And now what is actually going to make the difference is to having those continuous feedback mechanism where healthcare providers are going to be included from the design to the implementation to as well the post-implementation phase of those tools. And just to give you an example, so Estonia actually embedded those digital sandboxes and as well those environments where clinicians can provide real-time feedback on those tools, how they're helping them or how they're actually adding burden to the actual workflow. And I think this is definitely the way forward to making sure that this to minimize the gap that exists between those technology and the clinical reality. And this, of course, aligns perfectly with the so-called clinical adoption meta model, acronym is CAM. And this model actually stressed the importance of the post evaluation phase once those tools are available and as well used within the healthcare sector. And so it's not just going to be enough to train individuals on how to use these tools, but it's also going to be required to provide those training upskilling programs that are going to give clinicians the ability to as well critically assess those tools within their healthcare workflow. And of course, alongside Estonia, we also have 4 additional countries that are starting to build as well those formal feedback mechanisms. So this is something that is also starting to get momentum across OECD countries. And something that also should not be forgotten is that if we don't evolve the conditions from the onset, of course, there's going to be this direct impact on the usage and therefore on the impact. So we see actually the cyclical loop, if I can say like that, where if one, or bringing back the Lego analogy, if the first Lego is being missed, well, the other ones are not going to be fit in perfectly together. So I think this is also important to take into account, this aspect on trust. And just if you may allow me, I really like as well to think about that. So in the 19th century, I think everyone knows the Heinz, the ketchup bottles. So as one of their marketing coup, what they did is that they provided actually the list of all the ingredients that were contained in the bottles. And it was more in the sense to, show the customers or the clients to see what is really there in the bottle. And perhaps we should also start doing something similar with clinicians, is that they should also start having this understanding of what is in the AI tools, how it can be used, and what it can improve actually in their workflow. And I think this is also going to help perhaps to increase the adoption of those tools.
Okay. Thanks, Catherine, for touching up on bulk of the clinical part of it. So I would like to shift the focus a little towards a public health angle. Definitely, yes, designing process should involve the primary user that we are making this app for. I would like to start from where I stopped, right? So we understood that bulk of these technologies which are coming out of these vertical programs are not, really getting, a green signal or a good usability in the field, primarily because of a design challenge, right? So let's take an example of Instagram or YouTube. I know I'm trying to generalize it bulk, but nobody taught you how to use Instagram. Nobody taught you that if you push up, the reel is going to change, right? So it's a design that made it very intuitive for the user to understand. And then we need to understand that if we want something to be a success in the ground, you need to start working in the ground. So I would like to share the experience of one of the things that we did while we were trying to build an application which is called the Symbol app for the India Hypertension Control Program, where we sat with the nurses in Punjab and Karnataka and in various other states to start off. We sat with them, we did a storyboarding with them, we drew the app on paper and pen, asked them, where do you want the buttons? What do you want these buttons to do? What do you envisage this app to become for you? Right? And then we went on to design the app. Then we again went back to them. It was an iterative process, right? And it was never a waterfall where you keep doing and then pushing it for deployment. So we kept coming back, we kept going back. And finally, the success was we had around 2 million patients on board with multiple time point data, trying to give them specific indicators that the program wanted, that the district wanted, that the state wanted. This was a great lesson for us. And building on this, we are currently working on various field epidemiology techniques that solve problems in field epidemiology, trying to solve outbreaks, trying to solve surveillance systems, using similar aspect of sitting with these district epidemiologists, understanding their empathy journey to create solutions for them, right? Rather than me ideating and giving the, okay, this works best for you, use it. No, that's not the way that we might have to look at it, with the possibilities of the AI also. Now, with the AI, the possibilities are endless, which means you ideate also in that angle, and together using these AI to ideate and the ideas of the human, you build a system which will assist the particular individual in their day-to-day tasks, thereby making it easier to take it forward. Yes, I hope I answered it.
Okay. Thank you so much, Sharon and Katrina, for your response. And thank you for bringing in those very crucial human-centered perspective to the conversation. My next question is on a similar line, but Kehinde and Manoj, in traditional caregiving settings, a doctor, whenever they're making clinical decisions, they're always taking into account the patient's financial background, the patient's ethnic background, their non-medical clinical history, as well as the doctor is always applying, their own clinical intuition, and based on their years of experience, they're making those decisions based on all of these multiple factors. Whereas our AI systems make decisions solely on algorithms and data. Now, I wanted to ask you that how can we maintain the human-centered design principles such that when we're bringing AI into the caregiving dynamics, it's not isolating patients from their doctors, but rather enabling that relationship. I think, Manoj, you can go ahead first.
Yeah, great question. So every time we build out a solution there, especially anything to do with the digital tech that we are trying to deploy, we do a usability, acceptance, and feasibility study. And we carried this out with public health institutes. And what we understood for ourselves, even when we put in a simple intervention when we started out, we realized that there were so many kind of friction points that could just put this off, even if it was paid for, or it would just be shelved. And the reason would be as simple as saying they're not used to logging into systems before. And always we've had the thought saying we might be the first bit of digital technology that a healthcare worker is using in that scope. So we've been very mindful of this from the beginning. And that question on saying how do we bridge the gap, we're always in alignment with the fact that we want to augment the healthcare worker there, never kind of let the system take the decision and not take anything into conclusion. And very importantly, when we build these systems as well, it's not purely healthcare parameters alone. We do take a lot of demographic data. We do take a lot of parameters around specific to the location that they are, the parent, the maternal risk factors, lot of parameters that go in. Even if you have to predict something as saying if this baby is going to fall sick, what all could be the factors identifying. So we intuitively do take care of ensuring there's no bias in the system itself, but we build the system with a focus saying it is going to be enabling a healthcare worker to reach a decision. It could be a differential diagnosis, it could be a screening tool, but we want to ensure that it just augments and builds on top of what is the core for a healthcare worker. They do have to ask questions, they do have to do the history taking. This tool that we build, it could be in any form that we're deploying. We just try to say that this builds on top of the groundwork that you are doing. So that's one way that we try to ensure that we don't cause more friction into the system, because we realize that a lot of new points, right from digitizing, adding a health ID. These were all new things when we went into the field, saying these were not norms. When we asked what a health ID is, they just had baby off so and so. I said, really? But these were very surprising for us. And then we had to saying, okay, somewhere someone has to create an ID. So it started off with as simple as that, logging in, and all the way detailed to saying, what is the confidence level of this? Saying, how sure am I? Because I don't want to prescribe a test for not something that is not wrong. Worst case, which doctors came in with empathy and saying, what if I miss a case? So we had to balance out every bit of it when we were building system, especially when we are trying to put in a high-end technology right to the last mile. We had to take care of, ensuring there is a human touch always in it.
All right, thank you so much. I think Manoj has really touched on the critical areas. The biggest area that I've seen that can really help is just having that empathy and working with the end users to build a solution. That's the first step, having to bring the context into whatever system you're developing and also working off those contexts. And then whenever you're also building, from experience, is ensuring that whatever thing you're building also is in line with other architectures. Because that's something I've realized that we don't pay attention to. You are building for a doctor or a nurse, or let's say a community health extension worker, but they also have interactions with the other healthcare workers. So having to build the AI support, bringing that into the piece to ensure that whatever thing you're building for them also interacts with other healthcare workers, because they in their normal workflows interact. So ensuring that those things are there from day one. And I think the largest final piece here is that whenever you're also building for healthcare workers, ensure that you have testings done and be ready to continuously innovate in the system. Because if you think that the system you've developed and deployed as of yesterday would still work for today, then you're missing the entire point, right? So ensuring that for every developer who's supporting the government or the healthcare system, there is that clause that says you are also going to be ready to build and continuously innovate for a long term, not just deploying that solution, because that solution will need to be iterated. That model will need to be retested, need to be updated as it moves along. Thank you.
Thank you, both of you. We now have one last round of questions, and we're going to go through them very quickly in the interest of time. Now that we have AI already in the clinical settings, and they're now part of the patient-provider dynamic, Dr. Sharan, are we also seeing a trend where patients are actually demanding for AI-integrated care? And do you think there is also a case to be made for wherein patients perhaps might be more biased or trust a decision made by an AI system more than that made solely by a clinician?
Okay, so while we talk about this, Google is emerging as the doctor with the maximum patients with him, right? Yeah. So this question is very relevant, but in the setting of India, where AI has not come into the clinical practice as such. Now, I'm talking about the mass people, the public health sector, where the majority of the patients are going. AI has not penetrated in deeper into it, but there is a set of educated crowd which basically Googles their symptoms or tries to run it through ChatGPT or Perplexity, and then comes up with the possible, we call it differential diagnosis. And any one differential diagnosis in that could be a very scary one. And then if the doctor says maybe like take paracetamol and it should get settled in 3 days, they'll be like, but I also think maybe we should do this too, right? So it's currently it is just a factor that is playing around with an educated set of people who knows how to write a good prompt and maybe search for some symptoms. But overall, when you look at the population of India, it's still not a problem. Now, talking about the Western evidence, just to say that people are not very happy just to go with an AI-based diagnosis. They want a doctor to touch them. They want a doctor to feel them and then tell it. If that particular doctor whom they are consulting is using an AI to assist him, then it means acceptability is a little better. So like the doctor says, okay, I use this, and then it's validating it. So kind of, yeah, this is a possible scenario and we should move ahead in this, right? Say, for example, if you look at cancer treatments, right, when you apply a particular drug dose and then there is a lifetime associated with it, you can calculate the survival rates. What we were doing initially is basically trying to run an algorithm and find out what could be the possible person years that they can save, right, or we can that they can survive. So nowadays a doctor can basically run a set of papers that he wants, is as close as possible to his population. And from that, he runs a meta-analysis all by himself in Perplexity itself without having much knowledge. And then he tells, okay, it looks like you might survive for this many years. It adds more value. So it's doctor plus AI as an assist that is getting more value. Human first and then AI assist rather than, but we will take a longer time to reach into this conversation, India as a country. Yeah, that's it from my side.
Thank you so much, Sharon. Katrina, at the beginning, you gave us this data that there's been almost a 600% increase in the adoption of digital scribes. So my question is for Dr. Aseni, is that while hospitals and clinicians are taking up these new AI technologies like digital scribes or ambient AI, and these promise to help reduce administrative burden, but in the long term, are we seeing any impacts of AI on the clinical outcomes? Is there a benefit to this case, and also any measurable difference in the quality of care provided by doctors who are actively using AI?
Okay, thank you. I think we have two parts of health professional I have to use for this particular question, because we have a specific context in Africa. For physician or health practitioner at decision level and administrative level, the use of artificial intelligence reduce most of time the burden of works. But if we go to the frontline clinician side, we have different answer regarding that. I don't have evidence as a case study or article to use, but regarding feedback I got, I can say that for the first level, as administrative level, it reduced significantly the burden, but at frontline side, it's difficult. Why? In most of African countries, we don't have a system for a data collection at frontline level like electronic medical record system. We don't have in hospital. Some of hospital have, but it's most of time private hospital. How can we reduce a burden by using artificial intelligence if we don't have electronic medical record, for example, in the hospital? It's the integration of artificial intelligence tools to electronic medical record, for example, which will allow physicians to avoid duplication, to avoid the repetitive action, and also to make some analysis quickly and have answer and use clinical support, decision support system. You don't have electronic medical record at frontline side, it will not be possible to reduce the burden, but they can use the artificial intelligence for other administrative tasks to avoid this workload. This is what I can highlight. But regarding the studies I learned at United States site, I find that this use of scribe, for example, reduce significantly the time doctors spend on documentation and allow them to be more focused on patient. Also, I read article on the use of chat GPT for the patient care. And the article highlight that doctor who used both their own skill and the artificial intelligence have more result regarding the patient care than a doctor who were focused on their own skill. The second article also is regarding the use of artificial intelligence screening tools for lung cancer. If we combine both human skill and artificial intelligence, have a more result, which is perfect than the use of only artificial intelligence and also the use of human skill. Finally, I can say that the use of artificial intelligence regarding feedback I got reduced the burden of activities, of administrative activities, but we have to spend it into two types and not combine because of this lack of system. I know that in African region have most implementation regarding the data collection system, regarding the use of artificial intelligence, but we have to be more focused on what system we will use to have a good quality data, what system we will use to integrate artificial intelligence and not to have separate tools for artificial intelligence and increase the number of tools they have to use. If the number of tools increase, the health professional will leave the electronic, the digital tools and come back to the papers. But if you have at least a few tools to use and the other integrated with these few tools, I think it will reduce the burden of a healthcare professional. This is what I can highlight regarding that. Thank you.
Thank you so much, Hussaini. Audience, I know we are at time, but I would request you all to just stay for another 10-15 minutes and we'll try to wrap this up. I'm also going to request our speakers to try and keep their answers brief in the interest of time. Very quickly, my next question is for Anima. We're seeing the creation of AI tools which are now surpassing the abilities of human beings. There is this new AI tool which is able to twice as accurately detect brain stroke in patients than compared to physicians. Anima, do you believe that with the introduction of AI in the workforce, in the health workforce, we might unintentionally create systems which over rely on AI, and that as a consequence will result in de-skilling of our health workforce?
Okay, so twice as accurate sounds like the title of a Black Mirror episode. I don't think we should let AI do that. And as I will reiterate and emphasize on what Manoj said, right? That AI's real promise is in augmenting human cognition and not replacing it. So, as humans, it's also our collective responsibility to build solutions keeping in mind what we are solving for and not just building solutions for the sake of it, for replacing humans. I'll again give an example to talk about and answer this question. We have a solution which solves for diabetic retinopathy screening. So basically, it's such a simple solution that you and I can also use it. There's a camera which is attached to a phone. You click pictures of the eyes of the humans and it tells you whether there's diabetic retinopathy present in the eyes or not. Now, when you hear about it, you'd think that why do we need doctors then? But that's not true because this solution was designed strategically to fill a void. And that void is that we have lack of trained ophthalmologists in the healthcare settings, right? So there are lots of uh, healthcare facilities where these trained doctors will not be available. So optometrists or ashas or A&M, slightly lesser trained professionals can also start screening people and sort of reduce the work of ophthalmologists and the direct doctors who all these patients will go to. It in a way also democratizes quality healthcare and access to such healthcare where a person will have to go to a district hospital or to a higher facility can get these services at a lower facility as well. Now, to answer your question, the way I see it is not that it is replacing humans, but rather it's training a different cohort of healthcare professionals with something that they might not have access to owing to their medical degrees or like whatever they studied in their medical schools. So I think yeah, at the end of it, the core of it being how are we designing the solutions, what are we designing for? If we keep that in mind, I think AI will not de-skill people, rather it will sort of like match and augment whatever they currently know.
Thank you, Anima. And I think with AI systems, it's very important to remember that they are not free from error and, that the AI can make mistakes, right? Especially within a healthcare setting, an AI making an incorrect error can have some disastrous consequences, if not fatal. Candy, my question is for you. Within this provider patient dynamic and AI dynamic, in case an AI assisted clinical decision goes wrong or it goes awry, where does the liability or accountability lie?
Okay, so the accountability lies with everybody in the entire space. With the tech provider, which is usually the vendor that develops the solution for the different facilities. And that's why it's quite important that they're built with the healthcare worker so that during the testing phase, you can understand the outputs and you can and sign up that this system or AI solution is fit for purpose, right? Or regulators where they're meant to actually for ethics, validation of whatever solution will be used for the healthcare system. And even just providing that general oversight on the governments and regulators really have a major and critical role. And that's why in Nigeria, we have an initiative called the Nigeria Design Health Initiative. And one of their mandates is to ensure that there's that guidance and governance structure framework for the use of digital solutions in the country. And again, the final piece is, as a healthcare worker or practitioner, you also have a critical role to play because these systems are not there to for you to just pick it, garbage in, garbage out. It's for you to actually support, use the tool, support, and give you some bit of insights or some suggestion, recommendation. But the overall answers, and decision and final authority really lies with you because.
Candy, we lost you there. Okay. Hello?
As much as you want to develop an AI solution to have empathy, you cannot compare that empathy with a human empathy. And that's a patient, the demographic. Hello, can you hear me? Hello?
Yes, we can hear you now. Well, yes.
Hello, can you hear me?
Yes, yes.
Hello? Okay, sorry. I think okay. So what I was saying is the final accountability also lie with healthcare workers to ensure that they use this tool just to support their work and it doesn't take over the final authority of their clinical practice. And so everyone should be held accountable both from top to bottom, the governance, the government, the regulators, healthcare workers, and even the makers of this solution. Everyone should play a critical role in ensuring that, there's that quality and ethical backed solution that is used at the healthcare system.
Thank you so much, Kehinde. Manoj, now my question is to you. And so we just have two more questions to go and we will be uh, done with this. Manoj, as an innovator, what do you envision the next generation of AI tools to look like, and how might they support, a healthcare workforce? Are there any particular innovations or emerging technologies that you're particularly excited about?
So I think it's going to be some scene coming out of a sci-fi movie for sure, where I think epidemiology was a great example where maybe with a dial, I just zoom into a map with enough health data coming in from one particular region to understand what is the next epidemic or what's happening. Ambient AI systems with, say, voice-based interaction where a healthcare worker in real time can converse and the system prompts them saying what possibly could be wrong. So I think we're getting there right now. It's mostly text-based searches. I think the next frontier might be where almost real time a person's talking, chatting, something like a virtual assistant to healthcare workers. I think that's where I envision that it's moving towards. And all the pieces that maybe what the innovators are building and various agencies are developing will all become to one beat where we're going to augment the healthcare workforce, be it at the last mile or who are the patient facing folks. So I think that's where I see this going. And
Very
interoperable data, I think that's important, which Sharan also brought up, saying systems start talking to each other because there is quite some redundancy that all of us will start building. But when we have interoperable systems, this is going to be all the more efficient.
Wonderful. Thank you so much, Manoj. And the last question for today's panel goes to Katerina. And, we've been speaking about the workforce in AI for such a long time, but one very crucial workforce which we've not spoken about yet, it's the hidden workforce. It's the back-end workforce which, helps these AI systems work, right? We know that there are AI technicians which are there. We know that there is a technical back force which is working with the data, it's labeling the data, it's filtering the data. Katrina, my question is, how can we, in our ecosystems, start to recognize and value this hidden workforce a lot more?
Thank you, Sarah. Final word. We'll try to be quick. Just coming to the title of today's session, we're talking about the invisible force. I think this is the first thing that we should start changing, the language, how we call it. And this paper that is going to be published next year, where we analyze the adoption and impact of AI tools on healthcare professionals, we are also trying to broaden the definition of the healthcare workforce. It's not just frontline workforce, but it's those emerging roles, hybrid roles that I already talked about, and as well those back office roles. And the first thing to do to support the visibility of this workforce is to start collecting data. And across the OECD, we already have 4 countries that have started to do so either at a regional or at a national level. And the best example for that is the United Kingdom, for example, where they forecasted the demand for this so-called digital workforce, or as you said, this back office roles, where they forecasted a deficit of around 18,000 professionals by 2030. However, the demand in this digital workforce is going to be up to 40% by 2030. And this represents just 2% of the total workforce growth. So we see the real potential in making those roles visible, in collecting data, and this is as well going to help policymakers to have a better understanding of the workforce forecasting, and as well to ensure that these are integrated within existing workflows, and as well at the same time to provide frontline health workforce, as we already spoke throughout the discussion, to provide them the right upskilling trainings. And in that sense, one of the first countries, or actually 2 countries, have started to do that, namely France and Korea, have now officially embedded digital health/AI training within medical professions. But all in all, I think the first gesture is that we should start to making them visible in the language that we use.
I think that's a very, very beautiful note to end the conversation on. Katrina, thank you so much for your response. And thank you to all the panelists who shared their insights and experiences here with us today. We'll be doing a very quick Q&A round. So we have one question in our Q&A box, which is, what is your take on AGI, especially in healthcare in upcoming years? And anyone is free to answer that. Okay, never mind then. All right. I think that's it from our end. Thank you, everyone. And now I'm going to hand over the mic back to Eric.
Sure, thank you so much. First of all, I want to thank you, Sarah, for the fantastic facilitation, direction, my partner in crime around this whole series, and for Pallavi bringing together this youth network. I think it's really energized me in terms of what the art of the possible is in this space. I think the unanswered question around AGI is a hard one, and hence why there's like, well, it's really, is artificial general intelligence going to come? And frankly, I think we heard through the thing is like, well, if our focus is on using AI as an augmentation tool, then hey, it's great because it's still augmenting our performance as people in delivery of care. I particularly like the tone around the, if you want success from the ground, you have to work from the ground. Like that to me was just a very nicely put way, which really talks about the importance of involving the people who are impacted by this work. So again, I have more optimism for the opportunities around workforce, but I also recognize this is hard, and having people, the youth who are on this call, and frankly, people who have been attending this, gives me optimism for the future. Having said that, this is workshop number 4. We have 2 more webinars in our series. The one next month, and you'll get information about this in the next couple of weeks, is going to focus on regulation and ethics from guidelines to enforcement. So that will be, I think, really important because the whole point of regulation is not as a disabler of AI, which many people think of it as. It can be an enabler of AI if we do so responsibly and ethically. So I'm very much looking forward to joining with folks in a month. Thank you for those who have stuck around, and I look forward to seeing everybody in a month. And I should have added, thank you to our panelists.